Thank you. So thank you for your perseverance in being here on the last day. It's been a busy week. I'm afraid my voice and my feet didn't survive the party last night very well, so please bear with me. So we're going to consider whether we can prevent rhinosinusitis. These are my disclosures. And it is absolutely right that we're talking about preventative medicine. We would want to turn off the tap that's constantly dripping rather than try and mop up the flood. But it might seem a strange topic to have as our last plenary session, because surely we should be thinking about this at the beginning of the week. But what I hope I will be able to show you is that really this brings together some of the fantastic talks that we've heard throughout the week and will hopefully summarise and point us towards the future. Now, it is absolutely essential as a key principle of precision medicine that we would want to prevent disease. But it's important to try and remember why we might want to do so. Now, the key limitation of this talk is that, as we all know, chronic rhinosinusitis is such a mixed bag of conditions. So a lot of what I talk about may not apply to every patient with CRS or each aspect. And that's something that we will need to look at more in the future. So we know that chronic rhinosinusitis has a significant impact on the quality of lives of our patients. It has a significant financial burden through direct costs of healthcare and hospitalisation, but also an indirect impact through absenteeism and presenteeism. There are over 11 million doctor visits every year in the US, this is old data, and over £8 billion of expenditure. So it is absolutely right that we might want to reduce this. And it is highly prevalent. Here is Galen data that you all know well. But 10% of our UK population has chronic rhinosinusitis. It's one of the most common chronic diseases. Now, we can break down prevention into three main aspects. Primary prevention, where we reduce the incidence of disease by reducing exposure to risk factors. Secondary, where we look for early diagnosis and detection and correct symptoms that we might prevent chronicity. And then tertiary control, where patients are in a chronic phase, but we try to minimise the impact it has on their quality of life and normal functioning. So we'll start with primary prevention. Now, in order to reduce exposure to risk factors, of course we have to know what those risk factors are. And unfortunately, that's been very poorly studied in chronic rhinosinusitis to date. But we have evidence for smoking, occupational environmental exposure to irritants, and we'll consider acute infection, allergy, and although I won't be discussing it today, there's emerging evidence about genetic links. Now, unfortunately, in Europe, we top the league table for smoking, and this is something that we really need to look at. 28% of the European population still smoke. And we know that it's linked to the risk of chronic rhinosinusitis. There is very strong evidence. So very much as in Steve Durham's talk, this is an area we really need to focus on. Smokers are at increased risk compared to non-smokers, and it's dose dependent. There's a 1.5% increased risk for every additional year of smoking. And passive exposure of children increases their later risk in adult life. So we need to be thinking about this. We need to give smoking advice at every doctor contact, not just mentioning it, but proper advice. We need to refer patients to smoking cessation services, and we need to support them. We will often find that our patients say that their symptoms will get worse for a period before they get better. And some evidence from the Harvard group shows that it takes 10 to 20 years for their chronic rhinosinusitis symptoms and the condition of the lining of the nose to fully recover. There are, of course, other ways that we can reduce smoking through taxation, and unfortunately in the NHS in the UK, there's a suggestion that we should restrict access to surgery for patients across all diseases who smoke. Now, does chronic rhinosinusitis result from untreated acute rhinosinusitis? When we look at big data sets, electronic data, there seems to be a very strong risk factor. This data from Bruce Tan's group suggests that the risk factor is 3 times higher in patients that have acute rhinosinusitis. But of course that might be a failure of big data sets. We can never be sure that that first diagnosis of acute rhinosinusitis wasn't actually the onset of chronic disease. But there is some evidence from repeated aspirates from patients with acute rhinosinusitis of a change in bacterial flora. Now, we have very little evidence that the use of antibiotics in those acute episodes can influence the subsequent risk of chronic disease. And perhaps there's also a risk that those antibiotics may actually be harmful and change the underlying microbiome. We'll have seen many lectures over the week, but we know there is reduced diversity in the microbiome in patients with chronic rhinosinusitis. We don't know what causes that. The microbiome is largely established in the early years of life, but we do see reduced diversity in patients who have been treated with antibiotics, and this can have prolonged effects. If you treat a 2-year-old with a 1-week course of macrolide antibiotics, it changes their microbiome for over a year. And there's been some recent evidence that non-sinusitis-related antibiotic exposure is associated with an increased risk of developing CRS. So it's something, again, we need to think about. So what can we do? Well, acute rhinosinusitis, of course, is very common. It's usually self-limiting, and we have very good evidence that antibiotics make very little difference in terms of outcome and recovery. But in the UK, over 85% of primary care consultations for acute disease end up in antibiotic prescription. So we need to support our primary care doctors in withholding antibiotics, and we need to encourage the use of supportive treatments, except in the presence of complications. Does chronic rhinosinusitis occur more commonly in allergic rhinitis? Well, the literature remains highly controversial, but there's no convincing evidence that this is a risk factor. There's a very good recent systematic review with 10 studies, and although 7 found no association. We have no evidence that allergic rhinitis is associated with greater disease severity or treatment failure. And there's only weak evidence that treating allergic rhinitis improves outcomes in the underlying chronic rhinosinusitis. Of course, there's a lot of overlap of symptoms, but it doesn't seem to affect disease severity or progression. Now, these are people queuing to get into the European Rhinological Society conference on the first day. But in reality, actually, these are people queuing in the UK when a new dental practice opens up, and they're desperately trying to get on the books. And only 50% of our population, both adults and children, saw a dentist in the UK in the last 3 years. 1 in 3 Americans don't have dental insurance or access to dental care. And I think these numbers are getting worse, certainly in the NHS. We've got evidence that there are increasing numbers of visits to emergency departments and a definite increase in odontogenic sinusitis. And this is something perhaps that we often overlook. You know, this is someone with a clear periapical abscess, but it's not just that periapical lucency and erosion, but periodontitis is often associated with mucosal thickening in the floor of the maxillary sinus. So this is an area where we can actually lobby for our patients and improve access to care. Now, there's a relative paucity of data relating to occupational rhinitis, rhinosinusitis and exposure to toxins. But there is some evidence to support association with wood fumes, dust, gas and steam. And there's been some nice work recently by Stella Lee's group looking at exposure to particulate matter in both disease severity and risk of needing surgery amongst patients with CRS. But this is one of the most convincing slides, and this is a slide you've already seen earlier in the week with Hopkins. This is the rate of developing chronic rhinosinusitis in the first responders at 9/11. And this is dependent on how early they got to the scene. So the very earliest responders had the highest level of exposure to toxins and particulate matter. And you can see that over the 10 years after 9/11, 50% of that group developed chronic rhinosinusitis. So to me, this is the most convincing evidence that we need to be thinking about our environment and what we're exposed to on a daily basis. Now, gastroesophageal reflux disease, there have been recent systematic reviews showing an association, but the direction of that association still isn't known. There's no good evidence that treatment of reflux disease improves disease control or reduces the risk of developing chronic rhinosinusitis. There's been a very nice randomised trial looking at reflux treatment and postnasal drip, but of course that postnasal drip may not be related to chronic rhinosinusitis at all. So what do you do when the horse has already bolted, when it's too late to prevent disease? Well, we need to think about early correct diagnosis and appropriate treatment to prevent future exacerbations and chronicity. So we need better diagnostic tools, personalised care, we need to identify poor disease control, and we need to think about timely surgical intervention. Now, EPOS has given us a very good working definition of chronic rhinosinusitis based on simple symptom explanations, but it also requires some supporting evidence, either on endoscopy or CT. So if we just take this symptomatic definition alone, which is all our primary care colleagues have to go on, how good is that? Well, there's been some nice studies with patients having same-day CT and endoscopy. And the most important figure is this one. 50% of patients who have classic symptoms of chronic rhinosinusitis actually don't have the disease. They have normal endoscopy and normal CT. And it's perhaps no surprise, therefore, that it's difficult to get the diagnosis right. This is some work we've done very recently doing qualitative interviews with healthcare providers, asking them about how confident they are in making the diagnosis. And I think what's really interesting is that GPs actually feel very confident in making the diagnosis of chronic rhinosinusitis. They're pretty sure they get it right all the time. But the ENT doctors that see their patients report frequent incorrect diagnosis. And this isn't a failure of primary care, but it comes back to this, that many of our patients that have typical symptoms of chronic sinusitis don't actually have the disease. So that's a challenge. So we need to better train our medical students. In the UK, medical students spend 1 day in ENT. How are they ever going to get this right? And we need better education and support for our primary care physicians. And we need to encourage our primary care physicians to have some caution in reinforcing the diagnosis unless there is good supporting evidence on examination. And I think as secondary care physicians, unless there is an abnormal endoscopy, we should also think about point of care CT examination if it's available before we start medical treatment. So should we screen for chronic rhinosinusitis? Well, the Finnish allergy programme has been extremely successful and has demonstrated the benefit of rhinitis, instituting self-management. It would seem very attractive. We have restricted access to healthcare because of lack of money, certainly in publicly funded healthcare systems. And large proportions of our patients have smartphones and access to healthcare apps. So perhaps screening would be a good thing. But again, I think we have to remember that there would be some risks with that. Maybe 50% of our patients would wrongly self-diagnose themselves as having chronic rhinosinusitis. And as we start to encourage the use of these apps, we perhaps need to think about how we'll manage that group. I think one of the areas that has really improved has been our ability to better subgroup our patients. Now, we've typically relied on phenotypes, the presence or absence of polyps, and we have nice treatment algorithms for those two groups. But the problem is these aren't discrete groups. They are not clear ends of a spectrum. And what happens to those patients in the middle, where you can't see frank polyps in the nose, but they have a history of asthma? On their CT scan, you might see polypoid changes. So this is a patient who, when on endoscopy, would certainly be chronic rhinosinusitis without nasal polyps. But on CT and all other features demonstrates very much a polyp-type expression. And that's where endotypes are going to make such a difference to our practice. So we can define our patients better with biological markers that will actually predict their response to the right treatment options. And this will allow us to break our patients down into two main groups, Th2 type responses and a Th1 type response. And this is going to be critical in the future of better care. We've seen this slide throughout the week, and this is Klaus Backert's fantastic group in defining these different populations. And it will become much more important as we use monoclonal antibodies to treat our patients. It will allow us to separate that mixed bag I showed you at the beginning into a single homogeneous group that will better respond to a certain type of treatment. It will be critical in implementing precision medicine. We will be able to identify the most effective treatment at an individual patient level, and it will allow us to appropriately use new and potentially quite expensive drugs. It will allow us to identify the right one to give and the right patient to give them to. And although it might increase the total cost of care, it will certainly improve cost effectiveness in those very difficult to treat patients that often utilise very high levels of health care. Now, our current practice really involves repeated cycles of medical therapy. And while a significant number of our patients will respond, a lot of patients will get some improvement, will then decline. And there are repeated cycles where gradually over time they're actually getting worse. Luke Rudmit's group have done some very good studies that show actually patients who have refractory CRS who continue with appropriate medical therapy get a significant decline both in SNOT-22, endoscopic and radiological scores. So this group that are uncontrolled slowly get worse over time. And we've done some work at the UK looking at whether that impacts on their eventual outcomes. Now, in the NHS, we have limited finances. Patients often wait some time for surgery. So 50% of our patients having endoscopic sinus surgery will have had chronic rhinosinusitis for at least 5 years before that first operation. And that gave us an opportunity to explore their outcomes. What we found, dividing patients into those that had early surgery within a year of diagnosis, or late surgery, more than 5 years, so that big group that we saw, is that those that have surgery early on use a lower level of healthcare after that operation. This is the percentage of patients requiring active treatment for their chronic rhinosinusitis after their first operation. And what you can see is the early group, it's lower at all time points over a 5-year period. When we look at their rate of use of prescription medication, this is similar data repeated in the US, so in a very different healthcare system. For every year that surgery is delayed, ongoing use of prescription medications goes up year on year. And you can see it across all the different groups of medication: antibiotics, steroids, antihistamines. And perhaps this is the most important data. This is the health-related quality of life from our UK audit. We studied the percentage change in SNOT-22 score. So those patients that got their first operation within a year of diagnosis not only had greater improvement, but they actually got better over time, over that 5-year period. Whereas this late group, where surgery was delayed by 5 years, gets significantly worse. And at 5-year follow-up, are almost back to where they started. So there's growing evidence that delayed surgical intervention might be detrimental to long-term outcomes. But it is really important to say that this does not mean that all patients with chronic rhinosinusitis should have an operation, and it is not an excuse to operate on everyone that walks through your door. But we need an idea of how to better select patients to avoid that endless cycle of repeated medical therapy. And I think another thing that EPOS has done very well is give us an idea of disease control and allow us to define uncontrolled chronic rhinosinusitis. So if your symptoms are absent, you have normal endoscopy, you don't require systemic medication, your disease is well controlled. But if you have 3 or more, you would fall into the uncontrolled group, where it would be appropriate to consider surgery. This is also the sinus control test, another outcome which allows us to give this idea of uncontrolled disease. So this gives us a concept of when surgery is indicated, and it was a great pleasure to work with Luke Rugmick to, again, try to better define that. And this was quite a complex process to achieve consensus, where we defined minimum requirements for sinus disease. And the bar is set pretty low. Again, this is not something to suggest that everyone that meets this criteria should have surgery. But I think there is good agreement that everyone having sinus surgery should at least have some evidence of disease on CT. Surprisingly, we found as many as 1 in 4 patients in the UK audit had an almost or normal CT scan. You must have some symptoms, and you should have had a trial of appropriate medical therapy. There will always be exceptions to these criteria, and these are not meant to be used by reimbursement systems to exclude patients. But if we can at least try to target surgery at the most appropriate patients, I think we'll get better outcomes. So the final group is to look at the tertiary group, when disease is chronic and we want to reduce its impact. And it's estimated that about 30 to 50% of our chronic rhinosinusitis patients will fall into the uncontrolled group, despite evidence-based care. I think this is a very good framework from Peter Helling's group that gives us an idea on how we might manage those patients and what we must consider when they come back to us. We need to think about whether there are disease factors, and this will be where perhaps we might consider use of monoclonals or targeted therapy. We want to, again, reconsider the diagnosis and make sure that we got it right first time. We want to think about patient compliance, so we know that's something that patients are not so good at. And again, we want to check our own treatment to make sure we've given them the best available care. And things change with time. I think compliance is one of the areas where these smartphones will become particularly useful. Now, only 20% of chronic rhinosinusitis patients are actively using an intranasal corticosteroid, despite great evidence to show how effective they are. And it's probably both poor compliance and a little bit of underprescribing. But these smartphone apps will allow patients to remind themselves to take the medication. It will target and alert the patient when their disease control is going off. And I think these will be really useful in improving compliance in the longer term. The other thing we need to think about is to minimise the complications of the treatment that we prescribe to our patients. So intranasal corticosteroids, the risks are pretty small. Saline rinse. How often do we ask our patients whether they've changed their sinus rinse bottle? How many patients have the same bottle on their shelf for 2 years and are washing in some Pseudomonas into their nose? But I think perhaps antibiotic resistance is one of the greatest challenges that we face, and we really don't know yet the impact it has on the sinus microbiome. We all know about the risks of oral steroids, and I think we're all quite cautious, and certainly our patients are quite resistant to treatment. But I think we consider less the risks of some of the other treatments that we prescribe. So this is a recent systematic review looking at the safety of macrolides. Now, we're always told that we should avoid surgery. It's a last option because it's high risk. The risk of a CSF leak in surgery is probably about 1 in 1,500 patients. But when we prescribe macrolides, there's a risk in the region of about 1.5 patients for every 1,000 treated will have a macrolide-related cardiovascular event, an MI, and this is something that I think we don't consider as much as we should. We also need to manage our patients' comorbidities. There are very high levels of depression and anxiety found in chronic rhinosinusitis patients. And in the panel yesterday, I tried to highlight that I think one of my challenges is how that underlying depression can amplify my patients' symptoms. And that will often need management by their primary care physician to again help our patients get the best outcomes. So in conclusion, I think very much like Steve, we need to focus on smoking cessation. We need to think about an early, correct diagnosis, personalised treatment. We want to minimise the side effects of the treatment that we give and manage their comorbidities. It gives us an idea for future research needs. We need a better understanding of the role of antibiotics in preventing disease. We need better epidemiological studies to understand risk factors. We need to work with endotyping and see how we can apply that in routine care. And it will be exciting as we see the wider implementation of biologics. I'd like to thank you very much for staying with us this morning. I would like to thank everybody for coming to the meeting. I couldn't be happy with how it's turned out. In particular, I would like to give thanks to both Valerie and Vitsky for their support throughout and all of their help. And without it, I couldn't have done it. You've been fantastic. So thank you very much to everyone.